Hello, and welcome to another stream of Advanced Pathophysiology. Today we're talking about Chapter 19, the neurobiology of schizophrenia, mood disorders, anxiety disorders, and obsessive-compulsive disorders. We'll be talking about this chapter in its entirety, so without much further, let's jump right into it. Mental illness are common and found in different cultures and across the socioeconomic spectrum. When left untreated, the consequences can be devastating. This chapter provides an introduction to the neurobiology of schizophrenia, mood disorders, and some anxiety disorders. The etiology and pathophysiology of mental illness are diverse and complex. Diagnostic criteria are constantly being updated to more precisely diagnose and effectively treat the disorder. Every mental disorder manifests a range of symptoms that vary in intensity. Symptom variation likely reflect individual differences in pathologic brain structures and functions which affect treatment. Risk factors, such as exposure to uncontrollable psychosocial stress, may precipitate the onset of mental disorders and point to the challenge in understanding how disease genes and environmental factors interact. The development of visual and quantitative structural and functional neuroimaging techniques provides insight into the pathophysiologic basis of mental disorders. In schizophrenia, neuroanatomic, functional, and neurochemical alterations associated with the debilitating illness have uncovered abnormal brain regions, along with a host of candidate genes that confer risk. Similarly, in mood and anxiety disorders, brain scans are revealing structural and functional abnormalities. Notably, many brain regions implicated in normal cognitive and emotional processing are found in schizophrenia, mood, and anxiety disorders. The future lies in unraveling how the highly interconnected brain structures, modulated by neurotransmitters, neuropeptides, and hormones, operate in normal to abnormal mental states. Knowledge of the pathophysiology associated with a specific mental illness has guided the development of new psychopharmacologic medications with fewer side effects. However, some individuals with mental disorders do not respond to current medications or may relapse after a period of treatment. The use of psychotherapies alone or as an adjunct to pharmacotherapy also may be effective in treating some disorders by making the person aware of potential environmental factors that trigger stress and the onset of the illness. Learning to cope with these triggers offers hope for alleviating psychiatric symptoms or attenuates pathophysiologic functions. So, we'll jump right into schizophrenia. Schizophrenia is a serious psychiatric illness that strikes 1% of the world's population. The illness is equally prevalent in males and females and emerges in young adults during the late teens and early 20s, with a slightly earlier onset in males than in females. Schizophrenia is a term coined originally by Eugene Bleuler in 1911 to describe a collection of illness characterized by thought disorder, which reflect a break in reality or splitting of the cognitive from the emotional side of one's personality. A schizophrenic individual may exhibit a feeling of happiness when recollecting a terrible event or emotional indifference when describing a joyful occasion. Today, disorganized thought in schizophrenia is characterized by positive and negative symptoms, including auditory hallucinations, paranoid delusions, and cognitive deficits that have devastating effects on the individual and the individual's family. So, the etiology and pathophysiology. Genetic predisposition. Schizophrenia is a heritable disorder. In monozygotic twins, the concordance rate varies from 30 to 50%. This variability may stem from different diagnostic criteria and methodologic or sampling differences across studies. In dizygotic twins and siblings, the concordance rate decreases to 12%, which is still considerably higher than the 1% figure found in the general population. Nonetheless, schizophrenia is not a simple genetic disorder in which inherited diseases allele will always lead to illness. Schizophrenia likely involves several genes located on different chromosomes and differs from Mendelian disorders, in which genes are fully penetrant and recognized as the primary cause of the disease. As indicated by the 50% concordance rate in the monozygotic twins, the genes for schizophrenia show reduced penetrance, resulting in individuals who carry the disease gene without manifesting the illness. Further complicating the search for the specific genes that confer risk of schizophrenia is the variability in biologic and phenotypic traits among individuals who manifest the illness. Ongoing studies based on protein interaction may be valuable in identifying novel gene associations. Prenatal and perinatal vulnerability factors. Because the concordance rate of schizophrenia in monozygotic twins is never 100%, as in Mendelian disorders, environmental factors likely play an important role in increasing the risk of developing the disorder. A leading hypothesis suggests that early environmental factors interfere with genetically programmed neural development alterations that eventually compromise normal brain structures and functions. An early brain defect may remain silent and not dramatically affect the individual until subsequent development requires adaptive use of brain structures. Several hypothesized early environmental factors that may alter brain development and increase the risk of developing schizophrenia include exposure to prenatal infection, prenatal nutritional deficiencies, perinatal complications, and upbringing in an urban environment. Neuroanatomic and functional abnormalities. Neuroanatomic alterations. Advancing neuroimaging techniques have revealed structural brain abnormalities in schizophrenia. A consistent finding is the enlargement of the lateral and third ventricle and the widening of the frontocortical fissure and sulci. Schizophrenics with cerebral ventricular enlargement often exhibit cognitive impairments and negative symptoms and respond poorly to treatment. Other studies reported a reduction in the thalamus and temporal lobe areas. A reduction in thalamus size may disrupt neurotransmission between the frontal cortex and primary sensory and motor areas. Hippocampal volume loss in the first years of the illness is another consistent finding, and hippocampal volume reduction accelerates in schizophrenics more than 50 years of age. This hippocampal atrophy is strongly associated with global cognition and socio-occupational function impairments, which may also reflect a frontohippocampal disconnection in sociocognitive processing. So here you see the MRI comparison of a normal brain and a brain with schizophrenia. So hit pause so you can kind of, or not so much I hit pause, but you may hit pause so you can kind of take a look at the differences. The amygdala plays an essential role in the social brain emotional processing network. Abnormal amygdala connectivity is widely reported in schizophrenia and it hypothesized to represent the basis underlying pronounced difficulties for schizophrenics to make appropriate social judgments, as found in tests of facial identity, affect recognition, and emotional processing. Reported amygdala abnormality in schizophrenia include reduced volume and abnormal functional activation patterns for social and emotional processing. The induction of abnormal amygdala projections to brain regions, such as the hippocampus during late adolescence and young adulthood, may be linked to the onset of schizophrenia. Brain imaging studies in adolescents with early onset schizophrenia reveal progressive loss of cortical gray matter in temporal lobes. somatosensory, and motor cortices, and the dorsolateral cortex. Of clinical concern is the loss of cortical tissue, which is evident by the time the individual seeks treatment and continues throughout the course of the illness despite the use of antipsychotic medications. The progressive loss in frontal lobe volume is accompanied by increased severity of negative symptoms and further reduction in cognitive functioning. These results highlight the ineffectiveness of the current medication for schizophrenia to attenuate or reverse the loss of the frontal brain tissue. So here you see the accelerated gray matter loss in brains of early onset schizophrenia in adolescents. Brain abnormalities in schizophrenia are believed to originate in the prenatal period of cell proliferation and migration. Relin, an extracellular matrix protein involved in the neuronal migration during the development in synaptic function during adulthood, is reduced in the prefrontal cortex and hippocampus of schizophrenic individuals. Relin is concentrated in interneurons that contain gamma-aminobutyric acid, or GABA, the most widely spread inhibitory transmitter. Furthermore, in the dorsal prefrontal cortex of the schizophrenic brain, the level of glutamic acid decarboxylase, the major enzyme in GABA biosynthesis, is reduced, which likely impairs normal cognitive and emotional functions. The pathophysiologic changes in the dorsal prefrontal cortex are believed to contribute to the production of negative symptoms in schizophrenia. In particular, the dorsolateral prefrontal cortex is intricately involved in the initiation and maintenance of goal-directed activities and in solving cognitive problems related to working memory. Working memory involves the brief storage of use of information to complete cognitive tasks such as language comprehension, learning, and reasoning. Blood flow and metabolism normally increase in the DLPFC during working memory processing, but not in schizophrenics, who also perform poorly in tests of working memory. Thus, the dorsolateral prefrontal cortex appears to be hypoactive in schizophrenia. So here you're taking a look at the prefrontal cortex. Neurotransmitter alterations. The onset of schizophrenia was initially hypothesized to stem from abnormally high concentrations of the brain neurotransmitter dopamine. This dopamine hypothesis of schizophrenia was proposed on the basis of pharmacologic studies showing the antipsychotic drugs were potent blockers of brain dopamine receptors. A strong positive correlation was found between the clinical potencies of first-generation antipsychotic drugs and their affinity for the dopamine D2 receptor. In addition, drugs at high doses that dramatically increase dopaminergic transmission, such as levodopa, cocaine, and amphetamine, produced schizophrenic-like psychosis, which was reversed by dopamine blockers. A current view of the dopamine hypothesis of schizophrenia is that brain dopamine pathways are altered in different ways. For example, the negative symptoms and cognitive alteration in schizophrenia are proposed to result from reduced dopaminergic neurotransmission in the mesocortial or cortical dopamine pathway. This hypodopaminergic transmission in the prefrontal cortex contrasts with the hypothesized hyperdopaminergic secretion in mesolimbic brain regions that may contribute to the production of positive schizophrenic symptoms. The mesolimbic dopamine pathway innervates temporal lobe structures, including the hippocampal formation and amygdala, as well as the nucleus accumbens and anterior cingulate cortex. So here you see the dopamine system. A good spot to hit pause if you need to review how that works. Another neurotransmitter system that may underlie the pathogenesis of schizophrenia is the excitatory neurotransmitter glutamate and its action on the N-methyl-D aspartate receptor subtype. The glutamate hypothesis of schizophrenia proposes that underactivation of glutamate receptors contributes to schizophrenia. In schizophrenia, glutamate concentration in the cerebrospinal fluid are reduced along with a decrease in cortical glutamate synthesis. Furthermore, in unaffected individuals, blocking the glutamate NMDA receptor with antagonists such as the phencyclidine and ketamine facilitate the positive and negative symptoms of schizophrenia. PCP users report auditory hallucinations and disorientation and may become violent from their delusions. In monkeys, chronic PCP treatment impairs cognitive performance on a test associated with prefrontal cortical damage. So, what kind of clinical manifestations do we see in schizophrenia? The symptoms of schizophrenia are currently divided into three broad categories of positive, negative, and cognitive symptoms. Positive symptoms frequently occur during a psychotic episode, when an individual loses touch with reality and experiences something that should be absent, so hallucinations. Your negative symptoms are characterized by disruptions in normal emotional states and expression. Cognitive symptoms are fairly common and involve problems with thought processes that severely impair the ability to perform routine daily tasks that involve attention, planning, and social skills. According to the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders, the diagnosis of schizophrenia begins by eliminating other mental disorders and symptoms not caused by substance abuse, medication, or medical conditions. The individual will then be diagnosed with schizophrenia when at least two of the following symptoms, delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms are experienced most of the time during a 1 month period with some disturbance present over 6 months. In addition, one of the symptoms must be delusions, hallucinations, or disorganized speech. So in this box here, you see the major symptoms of schizophrenia. Your positive symptoms under hallucinations, delusions, positive formal thought disorders, bizarre behavior, leading us to negative symptoms, affective flattening, Alogia, Anhedonia, asociality, attention, Avolition, apathy, and your cognitive symptoms. I know I went through all that really fast. Please, please, please pause, review them, look them over, make yourself familiar. Your psychotic dimension. Psychotic dimension refers to hallucinations and delusions and reflects a person's confusion or loss of touch with the external world. Hallucinations and delusions are classified as positive symptoms and are the most common in schizophrenia. Hallucinations is the perception experienced without external stimulation of the sense organs. Sensory hallucinations can be auditory, tactile, vision, gustatory, and olfactory. An example of this, the schizophrenic individual may hear voices, experience touch or electrical sensations, report images of animate and inanimate objects, or complain of unpleasant tastes and odors. These hallucinations may occur alone or together. Delusions. A delusion is a persistent belief contrary to the educational and cultural background of the individual. Delusions may involve grandiose, nihilistic, persecutory, somatic, sexual, and religious themes. Paranoid beliefs are common and may involve spying, conspiracy, persecution, and ridicule. Delusions also may be referential in the particular stimuli, or events become highly personalized, such as believing a television talk show host is directing information specifically at them. Disorganized behavior. Disorganized behavior includes disorganized speech and disorganized or bizarre behavior. Incongruity of affect is another dimension of disorganized behavior. Disorganized speech. A common form of disorganized speech is formal thought disorder, which involves fluent speech that is difficult to comprehend. The speech often moves from one topic to another unexpectedly and illogically, and the person becomes easily distracted when talking. Another form of disorganized speech is called poverty of content. Here, the use of vocabularies to convey information is severely retarded, despite a fair amount of spoken word. For instance, the same phrase are used repeatedly throughout the conversation. Disorganized behavior. Disorganized or bizarre behavior is the conceptual equivalent of disorganized speech. The individual has difficulty engaging in goal-directed activities. Repetitive or aimless behavior and poor personal hygiene are exhibited. Another feature is oh my, struggling with incongruity of affect, or the manifestation of inappropriate situational affect, as exemplified by hostile, without provocative or childlike silliness in sober situations. Negative dimensions. Negative dimensions reflect a deficit in abnormal functioning and are characterized by affecting flattening, anhedonia, alogia, and avolition. Affective flattening is the near absence of emotional and facial expression through a conversation or in different situations. In anhedonia, individuals are unable to experience emotions such as pleasure or pain and report a sense of detachment from the environment. Alogia is the absence of spontaneous speech, production for the purpose of answering questions or expressing oneself. Avolition is a deficit in spontaneous or goal-directed behavior, such as completing simple daily tasks. So, how would we treat a patient who suffers from schizophrenia? To use the chlorpromazine in the mid-1950s dramatically altered the treatment of schizophrenia, which previously required extensive institutional hospitalization. The drug was especially effective in reducing positive symptoms such as hallucinations and delusions, as well as thought disorders and hyperactivity. The beneficial effects of chlorpromazine and similar first-generation antipsychotic drugs, such as haloperidol, on positive symptoms were believed to stem from their ability to block dopamine D2 receptor subtype, especially in the overly active mesolimbic dopamine pathways. However, D2 receptor blockade, such as in the striatum, produces a notable neurologic side effect resembling Parkinson's disease, a disorder associated with degeneration of dopamine cell bodies in the substantia nigra that project to the striatum. A related side effect of conventional antipsychotics that develop in 15 to 20% of schizophrenics after several years of treatment is a condition called tardive dyskinesia. This condition is characterized by a tic-like jerky movements, such as smacking of the lips or flicking of the tongue, unsteady gait, or rocking back and forth when seated. Other side effects may include sedation, hypotension, akathisia, constipation, weight gain, amenorrhea, and less frequently hepatotoxicity and electrocardiographic changes. Although the majority of schizophrenic individuals obtained some positive symptom relief from the first generation or conventional antipsychotics, roughly 20% failed to respond to deep-blocking drugs, especially those with pronounced symptoms of apathy, disorientation, and social withdrawal. However, some of these treatment-resistant individuals responded to a second generation of drugs that became known as atypical antipsychotic drugs. Atypical antipsychotics also were shown to have superior efficacy in reducing not only the positive but also the negative symptoms in comparison with conventional antipsychotics. An example, clozapine improves some cognitive function and some physical function. In addition, the notable neurologic side effects that accompany the use of the conventional antipsychotics were diminished. So here is a list of some medications used to treat schizophrenia. You're more than welcome to hit pause here just to kind of give it a glance over. Um, I'm sure we will see a lot of these drugs yet again when it is time for pharmacology. Unlike conventional antipsychotics, atypical drugs appear to work by blocking a range of neurotransmitter receptors. Another example, clozapine blocks not only D2 receptors, but also the D1, 3, 4, 5 receptors, and serotonin, norepinephrine, and cholinergic and histamine receptors. Risperidone and cyprosidone have higher affinity for blocking 5-HT2 than D2 receptors. The higher 5-HT2-D2 receptor binding ratio of atypical antipsychotics in comparison with conventional drugs may reflect a normalization of serotonin-dopamine interactions, leading to clinical efficacy not observed with D2 receptor blockades alone. Atypical antipsychotics are not without adverse effects. Most notably, metabolic abnormalities include regulation of glucose and lipid levels and weight gain. Another example, long-term clozapine or olanzapine treatment increases body weight gain, which becomes a risk factor for diabetes and cardiovascular disease. Schizophrenics treated with clozapine also are at risk of developing agranulocytosis, a potential lethal blood disorder involving the loss of white blood cells and a compromised immune system. In conjunction with antipsychotic medication, psychosocial therapy can facilitate the management of schizophrenia. Psychosocial relationships assist the individual in developing coping strategies and in identifying stressors and relapse symptoms. Cognitive behavioral therapy, a talking therapy that initiates cognitive and behavioral change based on an individualized reappraisal of the person's faulty beliefs, is effective in treating schizophrenics with stabilized antipsychotic medications. An important benefit of psychosocial and family support is encouragement of compliance with antipsychotic medications that require a period before the emergence of clinical efficacy. That leads us to mood disorders, depression, and bipolar disorder. Mood refers to a sustained emotional state, as opposed to brief emotional feelings, which are termed affective states. Healthy individuals are normally capable of experiencing a variety of affective states, including euphoria, joy, surprise, fear, sadness, anxiety, and depression. When emotional states, such as sadness, become chronic and uncontrollable, individuals may be diagnosed with a mood disorder called depression. The two major classifications of mood disorders are unipolar or major depressive disorder, also known as major depression or clinical depression, and bipolar disorder, which is further classified into bipolar 1 and bipolar 2 disorders. Major depressive disorder consists of depressed mood, loss of interest or pleasure, changes in activity, guilt, worthlessness, death, suicide, fatigue, loss of energy, decreased concentration, and changes in sleep, appetite, or weight. In addition, two new specifiers were added to the DSM-5. One specifier with mixed symptoms allows for the occurrence of manic symptoms as part of the diagnosis in depressed people who do not meet the criteria for a manic episode. Another specifier with anxious distress was added because anxiety may affect treatment choices for major depressive disorder. A manic episode consists of elevated, expansive, and irritable mood, as well as changes in energy and activity levels. In bipolar 1 disorder, the person experienced at least one manic episode that may be preceded or followed by hypomanic or major depressive episodes. Mania symptoms may significantly impair the individual, trigger psychosis, and require hospitalization. In bipolar 2 disorder, the individual experiences one major depressive episode for at least 2 weeks, and at least one hypomanic episode for at least 4 days. The following box presents the major criteria of major depression and bipolar disorder, according to the American Psychiatric Association, DSM-5. Again, I'm going to kind of go pretty quickly over this, so hit pause. If I'm going too fast for you, just pause if you definitely want to read over these. So, symptoms of depression, symptoms of manic episodes. Major unipolar depressive disorder is the most common mood disorder and the leading cause of disability in the US and throughout the world. Unipolar depression appears in all age groups, including young children. In the US, the lifetime prevalence rate is about 16.2% of the population, with a twofold greater risk in women than men after adolescence. In children and adolescents, 2 to 6% suffer from depression. The prevalence of bipolar disorder ranges from 3 to 5% in the general population. Bipolar 1 disorder occurs equally in men and women in comparison with bipolar 2 disorder, which afflicts more women than men. When left untreated, a number of depressed and bipolar individuals are at risk of developing a host of medical illnesses, including cardiovascular disease, obesity, diabetes, and thyroid disease. Etiology and pathophysiology, genetic predisposition, and environmental influences. Family and twin studies indicate a strong basis for mood disorders. Concordance rates for bipolar disorder ranged up to 62% and 42% for monozygotic and dizygotic twins, respectively. Concordance rates of 62 and 28% for unipolar disorder were reported in monozygotic and dizygotic twins, again, respectively. Even among adoptees with a biologic family history of mood disorder, the incidence of developing major depression or manic depressive illness is higher than among control adoptees. The strong tendency for mood disorders to run in families has encouraged a search for the abnormal gene or genes. Interestingly, loci on chromosome 18 and 22 have been linked to both bipolar disorder and schizophrenia. Bipolar individuals who may exhibit psychotic behavior have deficits in renin expression linked to genetic loci, located on chromosome 22, which confers susceptibility to schizophrenia. However, the large variation in clinical symptoms suggests that developmental and environmental factors are as important as genetic factors in contributing to the etiology of mood disorders. Neurochemical dysregulation. Modern theories of mood disorders began with the import observation that drugs such as imipramine that elevated norepinephrine levels within the synapse reduced depression, whereas drugs that depleted monoamine levels increased depression. These studies led to the dominant monoamine hypothesis of depression, in which a deficit in the concentration of brain norepinephrine, dopamine, and/or serotonin is the underlying cause of depression, in contrast to mania, which results from elevated concentrations of monoamines. Three major classes of antidepressant drugs were initially developed and included monoamine oxidase inhibitors, your tricyclic antidepressants, and selective serotonin reuptake inhibitors. These antidepressants shared the common property, albeit through different mechanisms, that increasing monoamine neurotransmitter levels within the synapse is the basis for their antidepressant antidepressant effects. Oh my goodness. So here is a picture of schematic diagrams showing the sites and actions of antidepressants and their effects on neurotransmitters levels. So it's a good spot to hit pause to kind of hit that review if you're unfamiliar with how they function. Additional support for monoamine hypothesis of depression came from studies showing a reduction of monoamine metabolites in the cerebral spinal fluid of depressed people. Other work demonstrated that dietary depletion of tryptophan, the precursor of serotonin synthesis, or alpha-methylylperoxytyrosine, a drug that inhibits dopamine and norepinephrine synthesis, produced a rapid return to depression in individuals successfully treated with antidepressants. So, neuroendocrine dysregulation, stress, and hypothalamic pituitary adrenal system dysregulation. The hypothalamic pituitary adrenal system plays an essential role in an individual's ability to cope with stress. However, chronic stress-induced activation of the HPA system and elevated glucocorticoid secretion are found in large percentages of people with major depression, suggesting that mechanisms responsible for increased HPA hormone secretion contribute to the pathophysiology of depression. Notably, antidepressants, drugs effective in normalizing the HPA system, are associated with a good clinical response, whereas persistent dysregulation of the HPA system is related to continued depression or relapse. Psychosocial stress-induced activation of the immune system increases secretion of pro-inflammatory cytokines, such as interleukin-1 alpha and interleukin beta, tumor necrosing factor alpha, and interleukin-6, which modulates signaling pathways throughout the periphery and brain, and augments further secretion of HPA hormones and monoamine metabolism. Evidence suggests that inflammation is another risk factor that triggers the onset of depression. Another example, a study involving 73,131 Danish individuals from the general population reported elevated levels of C-reactive protein, a commonly used marker of inflammatory disease, was associated with increased risk of psychologic stress and distress and depression. Another study reported that depressed people treated with antidepressants, a combination of antidepressants and psychotherapy, or psychotherapy alone, initially exhibited elevated cytokine levels that returned to normal levels after recovery from depression. These studies suggest that cytokines are involved in the pathophysiology of depression. So, again, a good spot to hit pause if you want to read more about what's new in terms of inflammatory cytokines. I'll stop, like where a good spot is for you to pause so you can read as much as you can about it. I try to give you those options. Increasing evidence from animal models of stress-induced depression shows that depression-like behavior is accompanied by atrophy of neurons in the hippocampus, a reduction in the development of the new hippocampal neurons, and deficit in hippocampal brain-derived neurotrophic factor levels. Consistent with animal studies, human postmortem work indicates low hippocampal BDNF levels in depression. Because the growth factor BDNF supports the survival of neurons and facilitates neurogenesis from hippocampal stem cells, a neurotrophic hypothesis of depression has been proposed as an extension of the monoamine hypothesis of depression to broadly account for the pathophysiologic basis of depression. That is, stress-induced depression and the accompanying reduction in levels of monoamines are caused by deficits in neurogenesis and BDNF levels. Of clinical relevance, administration of antidepressants to animal reverses the depression-like state and increases the development of neurogenesis and BDNF levels. Your hypothalamic pituitary thyroid system dysregulation. Alterations in thyroid function and mental illnesses, particularly major depression and anxiety disorders, have long been recognized. People with hyperthyroidism often manifest symptoms of dysphoria, anxiety, irritability, emotional lability, and cognitive impairments. On the other hand, individuals with severe hypothyroid exhibit features of major depression, apathy, psychomotor slowing, and dementia. Notably, although thyroid dysfunction may be linked to symptoms of depression and anxiety, people diagnosed with primary depression generally have normal thyroid function. The causal mechanism or basis underlying altered thyroid secretion and depression remain to be determined. Your neuroanatomic and functional abnormality. The dorsal and median raphe nuclei, located in the central gray matter of the caudal mesencephalon and rostral pons, contains a large group of serotonin-synthesizing neurons that project extensively to all regions of the cortex, basal ganglia, limbic system, hypothalamus, cerebellum, and brainstem. Postmortem and/or brain imaging studies of depressed individuals revealed a widespread decrease in serotonin 5-HT1A receptors, subtype binding in the frontal, temporal, and limbic cortex, as well as serotonin transporter binding in the cerebral cortex and hippocampus. Mood disorders in some people may reflect a dysfunctional raphe serotonin system, which normally modulates homeostasis, emotionality, and tolerance to aversive experiences. So here you see the serotonin system. Again, a good spot to hit pause if you're unfamiliar. A group of norepinephrine containing cells located in the locus cereosus of the rostral pons project to vast areas of the forebrain, brainstem, and spinal cord. The locus cereosus norepinephrine system is implicated in global psychologic processes, including attention, vigilance, and orientation to novel, aversive, or threatening stimuli. Activation of the locus cereosus norepinephrine system is capable of inhibiting the RAF serotonin system, suggesting an indirect role in modulating serotonin functions. Norepinephrine receptor alterations are found in the frontal cortex of some suicide victims with major depression. Alterations in norepinephrine systems may be linked to attention or concentration difficulties, as well as sleep and arousal disturbances in depression. So here is the norepinephrine system. Functional abnormalities associated with mood disorders are found in frontal and limbic regions, such as the amygdala. Postmortem studies report a reduction in glial cell numbers in people with unipolar and bipolar disorders. There are also reports of reduced frontal lobe volume in depressed individuals and decreased or asymmetric temporal lobe volume in individuals with bipolar illness and depression. Functional neuroimaging studies indicate decreased cerebral blood flow and glucose metabolism in the dorsolateral and dorsomedial prefrontal cortex of individuals affected with major depression or bipolar disorder. Dorsolateral prefrontal abnormalities in depression may be responsible for the retardation in cognitive processing and speech deficits similar to those found in schizophrenia. Dorsomedial frontal dysfunction may be associated with the mnemonic and attention impairments that accompany mood disorders. Other frontocortical regions, including the ventrolateral, ventromedial, and orbital areas, exhibit increased blood flow and metabolism in unipolar depression. These frontal brain areas have extensive interconnections with the amygdala and increased blood flow and metabolism. especially in the right amygdala, are positively related to negative affect in depressed individuals. These functional changes in brain activity begin to normalize with successful antidepressant treatments, suggesting that they state rather than trait related. So here you're taking a look at a PET scan, and you see the comparison of brain activity in depression and the remittance. Hippocampal volume reduction in major depression is widely reported finding, especially in people with a history of recurrent major depression. Similar to the hippocampus, the amygdala is reduced in volume after experiencing a number of major depression episodes and a family history of depression, albeit enlarged in first episode depression. The cumulative effects of stress may be responsible of a reduction in hippocampal and amygdala volume. MRI studies showed increased volume of the amygdala in bipolar illness in larger lateral ventricles in people suffering multiple bipolar episodes, compared to those with only a single episode or healthy controls. Ventricular enlargement suggests progressive brain tissue loss resulting from multiple bipolar episodes. The glutamate system, because of the late onset of action of current antidepressants and poor remission rates, investigators are constantly searching for new drugs with novel mechanisms of action. An emerging body of evidence suggests that elevated cortical levels of glutamate, the major excitatory neurotransmitter in the central nervous system, may be involved in the pathophysiology of major depression. A potential promising target is the glutamate N-methyl D-aspartate receptor. At non-toxic doses, the glutamate receptor antagonists, ketamine, was found in animal models to rapidly increase synaptic density and signaling in cortical neurons. Of clinical relevance, a few studies reported ketamine was effective in inducing rapid but transient antidepressant effects in treatment-resistant depressed people. Further research on unraveling the mechanism of action of ketamine and on the long-term safety and efficacy of ketamine will be required before this drug can be recommended as an alternative innovative treatment for depression. So, clinical manifestations of depression. Major depression is characterized by unremitting feelings of sadness and despair. The dysphoric mood, or intensely painful mood, is accompanied frequently by insomnia, loss of appetite and body weight, and reduced interest in pleasurable activities and interpersonal relationships. Sleep disturbances may include difficulty in initially falling asleep and awakening in the middle of the night, lying awake for several hours with inability to subsequently fall asleep. Individuals may have reduced motor activity and suffer marked fatigue. Others complain of restlessness and agitation. Feelings of worthlessness and guilt are common. A pessimistic or negative outcomes are often perceived even in routine situations. The ability to function and concentrate is greatly diminished. Depressive episodes may occur or recur suddenly or gradually and continue from a few weeks to months, and 20% may exhibit a chronic form of depression. Suicidal risk increases in depression. Factors such as living alone or being divorced, have a prior history of drug abuse or suicide attempt, or having depression at midlife or older ages contribute to suicide in 10 to 15% of depressed individuals. That brings us to bipolar disorder mania. Manic individuals experience elevated levels of euphoria and self-esteem and feelings of grandiosity. Energy levels are greatly enhanced even after only a few hours of sleep each night. The increased energy, however, does not lead to organized plans and thoughts. The individual may show poor judgment in spending money, may become hypersexual, or may make poor business commitments. Other hallmarks of mania are excessive, rapid, loud, and pressured speech. The manic person frequently skips from one topic of conversation to another and is easily distracted both when speaking and when performing tasks. Roughly 50% of manic individuals develop psychotic symptoms, such as delusions or hallucinations, which require hospitalization. The onset and termination of manic symptoms are usually abrupt and may last for a few days or months, followed by depression. The risk of recurrence of bipolar disorder is high, especially without immediate treatment. So, treatment of depression. 80% of depressed persons will respond to antidepressant drugs such as MAOIs, TCAs, and SSRIs. Again, that table from 19.2. Psychotherapy, or a combination of both treatment modalities. Although SSRIs have become the standard first-line treatment for major depression, initial selection of an antidepressant often includes an assessment of the person's symptoms and age, as well as the side effects, safety, cost, and convenience of the prescribed medication. For example, medications that produce sedation may be helpful for the treatment of sleep disturbances. Again, roughly 50% of depressed individuals may not show a favorable response during initial treatment to an antidepressant drug, and 10 to 20% may continue to exhibit symptoms after 2 years. Individuals who are non-responsive to the specific antidepressant during a 2-month period may be given another antidepressant medication. Atypical antidepressants, such as nifazodone, trazodone, and mirtazapine, presumably produce their clinical effects by blocking specific receptors. A new generation of antidepressants that selectively block serotonin and norepinephrine reuptake is available in the US and Europe. At present, there are no criteria to determine whether selective I'm struggling. At present, there is no criteria to determine whether selection of the next antidepressant will be efficacious. Among children and adults, only fluoxetine is currently approved for the use by the US Food and Drug Administration. So here we're looking at some FDA-approved medications. Here is a good spot to hit pause if you're unfamiliar with medicines. Again, I feel like we will see these a lot more in our pharmacology classes that are coming up. Or if you're taking pharmacology already, then you may be familiar with them already. Or if you're working in a clinical setting. And here is a box of comprehensive treatment of risk factors. May promote resilience and rapid recovery from depression. So again, hit pause if I'm going too quickly. The information never hurts to have. And I'll try to see if I can hit, a semi-pause on my side so you can read the entirety of it. In bipolar depression, antidepressant medications may lead to cycle acceleration or induction of mania. However, SSRIs and bupropion may be less likely to induce these effects than MAOIs and TCAs. A number of side effects are reported with MAOIs, TCAs, and SSRIs. Commonly reported side effects of MAOIs include sedation or agitation, insomnia, dry mouth, impotence, and weight gain. MAOIs may also induce acute and heightened elevations in blood pressure after intake of a tyramine-rich food, such as aged cheeses, sour cream, pods of broad beans, pickled herring, liver, canned figs, raisins, and avocados. In addition, MAOI interactions with TCAs and SSRIs, stimulants, and over-the-counter flu medications are dangerous and should be avoided. Because of adverse side effects, MAOIs are used less often than other antidepressants. TCAs may produce sedation, insomnia, orthostatic hypotension, seizures, and weight gain. Some TCAs have moderate anticholinergic side effects, including constipation, urinary hesitancy or retention, dry mouth, blurred vision, and memory impairment. These side effects may be an issue when considering TCA treatment of older adults, in which case the TCA dyspromine and nortriptyline may be preferred because of their reduced anticholinergic, cardiovascular, and sedating effects. Common side effects of SSRIs include sleep disturbances and nausea. However, agitation, allergic skin reactions, dry mouth, anxiety, altered appetite, and sexual dysfunction have been reported. Unlike MAOIs and TCAs, SSRIs do not have pronounced effects on the cardiovascular or cholinergic system. SSRIs are potent inhibitors of cytochrome P450 isoenzymes, which are involved in drug metabolism. Therefore, SSRIs may lead to dangerous elevations in blood concentrations of other psychiatric medications when taken together. SSRIs should not be taken with MAOIs or immediately after discontinuing MAOI treatment. A serotonin syndrome characterized by excitement or autonomic hyperactivity, abdominal pain, rigidity, and hyperthermia may develop, leading to a coma and even death. Side effects of atypical antidepressants may include sedation, dry mouth, weight gain, and constipation. Nifazodone and trazodone have been associated with a hepatic toxicity. Venlafaxine and reboxetine lack many of the serious side effects associated with TCAs. However, sweating, dry mouth, and some sedation may occur. Electroconvulsive therapy may be used when individuals fail to respond to antidepressants or when they are severely depressed, pregnant, suicidal, or psychotic. Electroconvulsive therapy effectively alleviates depressive symptoms in about 50 to 80% of people, who may then begin to respond to antidepressant medications. Recent work suggests that ECT increases the volume of the hippocampus and amygdala, brain structures linked to emotion. I feel like I mispronounced that. Recent work suggests that ECT increases the volume of the hippocampus and amygdala, brain structures linked to emotion, mood, and cognitive functions. Depressed people with relatively small hippocampal volume were more likely to show hippocampal volume increases and improved clinical response to ECT. Neurotrophic processes activated by ECT, including neurogenesis, may underlie these structural changes and clinical benefits. Deep brain stimulation is another treatment showing promise to alleviate major depression in people resistant to current antidepressant medications. ECT and psychotherapy. The treatment involves implantation electrodes during neurosurgery into the brain regions such as the subcallosal cingulate gyrus and the nucleus accumbens. This SCG region was targeted because abnormal SCG brain activity, a suggested pathophysiologic cause of major depression, is reversed by effective antidepressant treatments. A 3 to 6 year follow-up study of 20 treatment-resistant depressed individuals who received DBS in this SCG found more than half eventually returned to work and improved their quality of life. Preliminary work with DBS in the nucleus accumbens, a region involved in rewarding experiences, was shown to reverse treatment-resistant depression in people unresponsive to pharmacotherapy, psychotherapy, and ECT. Pathophysiologic in the nucleus accumbens may be linked to impairments in reward processing and underlie the anhedonic symptoms of depression. Preclinical studies suggest that the mechanism responsible for reversing the anhedonic state of depression is caused by rapid increase in monoamine release in the prefrontal cortical areas, following DBS stimulation in the nucleus accumbens. Another therapy for treatment-resistant depression is transcranial magnetic stimulation. This FDA-approved treatment involves non-invasive focal brain stimulation. Unlike DBS, which requires neurosurgery or ECT seizure induction, the procedure uses an electromagnetic coil to create a magnetic field that passes from the scalp to the brain, where the electrical current flow stimulates neurons. Daily repeated left prefrontal TMS was shown to induce acute antidepressant effects, with few side effects and remission in 30 to 40% of depressed people. A weakness of many antidepressant treatments is that even among individuals who receive the gold standard of antidepressant pharmacotherapy and psychotherapy, at least 50% of people who recover from the first episode of depression will nonetheless experience another one or more depression episodes in their lifetime. The recurrence rate of depression increases to approximately 80% of those with a history of 2 episodes. One contributing factor for relapse is the failure of people to continue with their treatment plan by stopping the therapy session or drug medication. Another related factor is a low social support and perceived loneliness. Studies reported low social support predicts poor response to depression treatment, early dropout, and heightened risk of relapse. Interventions aimed at increasing social interactions may prove to be valuable in reducing depression symptoms and relapse. So here's another study, are nutraceutical effects on the treatment of depression. A good spot to hit pause and read the article. I'll try to stop it at spots that make sense. So, bipolar disorder. FDA-approved treatments are available for bipolar disorder. Individuals with bipolar 1 disorder are usually treated with lithium, the first choice of treatment to control mania and rapid cycling and to reduce the risk of suicide. In some cases, lithium in combination with SSRIs is used to treat bipolar disorder. In addition to lithium, several medications are used, including anticonvulsants or atypical antipsychotics. Some bipolar individuals benefit from thyroid augmentation, as in depression. ECT is administered with manic individuals, fail to respond to medication, are pregnant, or have cardiovascular disease. Frequently reported side effects of lithium treatment include increased thirst, tremor, diarrhea, and weight gain, which diminish over time. A potential serious side effect of lithium toxicity. Lithium is normally removed from the kidneys. However, when the body is sodium depleted, the kidneys will reabsorb sodium along with lithium. Individuals receiving lithium treatment are advised to avoid physically demanding activities that may dehydrate the body and to seek medical attention during fever or other conditions that may increase sweating. Anticonvulsant treatment may produce unsteadiness, dizziness, tremors, nausea, and blurry vision. In addition to pharmacotherapy, psychotherapy can be beneficial for those who have difficulty with psychosocial stressors, such as low self-esteem, legal problems, fear of recurrence, and interpersonal conflicts. Treatment is effective when individuals become aware of bipolar disorder, copes with psychosocial stressors, engages in drug compliance, and monitors symptom recurrences. Unlike treatment of mania and bipolar 1 disorder, a major focus in treatment of bipolar 2 disorder, the less severe form of mania, is on recurrent depressive symptoms. Here, antidepressants alone are reported to be effective in treating bipolar 2 disorders. The treatment of bipolar 2 in children has raised concerns because of complications with its diagnosis. For example, bipolar 2 and attention deficit hyperactivity disorder share the common features of elevated behavioral activity levels, excessive talking, restlessness, and distractibility. Misdiagnosing bipolar 2 as ADHD has negative consequences for treatment because the stimulant drugs, Ritalin and Adderall, which are frequently used to treat ADHD, will potentially exacerbate the symptoms of a child with bipolar 2 disorder. On the other hand, when ADHD is misdiagnosed as bipolar disorder, the child may begin an ineffective treatment regimen to reduce misdiagnosis of children with bipolar and other similar symptoms, characteristics such as ADHD, as well as conduct disorder and oppositional defiant disorder. The DSM-5 now includes a category called disruptive mood dysregulation disorder. This diagnosis will be used to describe a young child between 6 and 10 years of age who exhibit only some of the symptoms of bipolar II, such as frequent temper outbursts, irritability, and bad mood. This category is hoped to exclude children from being diagnosed with bipolar disorder and reduce possible unwarranted treatment with strong medications. Anxiety disorders. Fear and anxiety are normal feelings expressed when or in threatening or harmful situations. The symptoms may include arousal, tenseness, and increased autonomic activity, such as heart rate, blood pressure, and respiration. In addition, individuals often engage in protective behavioral responses, such as flight or avoidance. These physiologic and behavioral responses allow humans to adapt and cope under a variety of situational challenges. However, when fear and anxiety become too intense and undermine the ability to function on a daily basis, the individual may develop an anxiety disorder. Anxiety disorders are the most prevalent psychiatric illnesses, occurring in approximately 10 to 30% of the general population. Notably, many individuals with anxiety disorder develop major depression, and the high comorbidity of anxiety disorders and depression suggest a common neural pathophysiologic basis linking the two mental illnesses, including panic disorder, social anxiety disorder, generalized anxiety disorder, and post-traumatic stress disorder, which in DSM-5 is listed in the chapter on trauma and stressor-related disorders. Your panic disorders. Panic disorder consists of multiple disabling panic attacks and is characterized by intense autonomic arousal involving a wide variety of symptoms including lightheadedness, a rapid heart rate, difficulty breathing, chest discomfort, generalized sweating, general weakness, trembling, abdominal distress, and chills or hot flashes. Between panic attacks, the individual often worries about future panic attacks and fear of losing control and dying. Symptoms originally occur spontaneously and vary in length from several minutes to an hour. A notable complication of panic disorder is the development of agoraphobia, or phobic avoidance of places or situations where escape or help is not readily available. The agoraphobic individual will avoid being away from home, standing in line or in a crowd, or traveling in a train, plane, or automobile. Severe agoraphobic individuals become housebound. The etiology and pathophysiology. Genetic factors play a major role in panic disorders. The risk is nearly 20% among first-degree relatives, and the prevalence of panic disorder is about 1.5% in men and up to 3% in women with no family history of the illness. Some studies suggest that the cholecystokinin receptor gene on chromosome 11p may be linked to panic disorders. The etiology of panic disorder is not known, but the ability to elicit physical symptoms of panic attacks by chemicals called panicogens provides insight into the pathophysiology. Panic-prone individuals respond to panicogens that include carbon dioxide, caffeine, cholecystokinin, sodium lactate, and adrenergic receptor agonists such as yohimbine. Carbon dioxide and sodium lactate, two well-studied panicogens, alter brain pH balance that panic-prone people are sensitive in detecting. Brain pH chemosensors are located in the brainstem, medulla, and pons. The midbrain serotonergic, RAF neurons, and hypothalamus, and the amygdala. Heightened pH sensitivity in the amygdala may play a key role in generating fearful perceptions and activating the cerebral cortex and neural circuits in the temporal lobe and brainstem, which further facilitates the production of panic symptoms. Exaggerated activation of the physiologic and behavioral arousal stemming from the noradrenergic locus cerebralis neurons also may enhance the symptoms of panic. Thus, panic-prone people appear especially sensitive in detecting pH alterations in brain sites that modulate fear and arousal. So here again is a picture of the limbic system. Panic disorders also may involve the GABA benzodiazepine receptor system. Your GABA benzodiazepine increases the GABA-A ion channel response to GABA, thereby elevating chloride ion influx and producing a neuronal inhibitory effect. Brain imaging works reveals a reduction in BZ receptor binding in brain regions, including the hippocampus, insular, and prefrontal cortex. Drugs that block the benzodiazepine receptor are reported to increase panic attacks and feelings of anxiety, suggesting that an alteration in inhibitory neuromodulation contribute to panic disorders. So, our treatment for patients with panic attacks. Up to 80% of individuals affected by panic disorder respond to CBT and antidepressant drugs, either separately or in combination. In CBT, the individual learns that the physical symptoms are not fatal and attempts to exert control over the anxiety and panic. For example, breathing exercises to control hyperventilation serve to lessen the intense physiologic symptoms of panic, such as elevated heart and respiration rates. Another benefit of CBT is awareness of compliance with drug medications. However, for individuals with mild agoraphobia, CBT alone may be effective. Antidepressants such as SSRIs are considered first-line medications for panic disorder. Among the SSRIs, paroxetine and sertraline have received FDA approval, especially for panic disorders. Venlafaxine, a serotonin norepinephrine reuptake blocker, also is effective. BZs, such as alprazolam and clonazepam, are the other medications for treating panic disorders. These drugs also serve as an adjunct or augmentation therapy for individuals who do not fully respond to SSRIs. Short-term effects of BZs include sedation, ataxia, and cognitive impairments. Long-term BZ treatments may lead to potential physiologic and psychologic dependence. Abrupt BZ withdrawal induces a withdrawal syndrome of heightened reemergence of anxiety, insomnia, photophobia, and diarrhea. A gradual reduction in BZ medication or adjunct CBT may reduce the reliance and withdrawal symptoms of BZs. Social anxiety disorders. Social anxiety disorder, or SAD, also known as social phobia, is characterized by fear and avoidance of social situations. An example, the anxious person may feel very uncomfortable having a conversation or interacting with others, and very conscious of being scrutinized and humiliated or rejected by others. A person diagnosed with SAD suffers significant distress or impairment that interferes with ordinary routines in everyday social settings, at work or at school. Epidemiologic surveys indicate that SAD is one of the most common psychiatric disorders with 12-month and lifetime prevalence rates of 6.8% and 12.1% respectively. The onset of SAD often occurs during adolescence. As with adults, children with SAD exhibit fear of speaking, reading, and eating in public, going to parties, speaking to authority figures, and engaging in informal social interactions. Your etiology and pathophysiology. A prominent finding from brain imaging work with SAD people is that increased activity found in the limbic and frontal cortical areas. Exposure to facial expressions of threat, which hypersensitive SAD people are likely to perceive as extreme dislike, rejection, or criticism, often implicates the amygdala and its connections to other brain regions. Heightened anxiety in SAD may arise from deficits in the inhibitory tone from prefrontal cortical areas to the amygdala, resulting in increased amygdala activation and a fear bias in threat-related processing. Support of abnormal signaling comes from work showing decreased white matter connectivity between the amygdala and orbitofrontal cortex. Neuroimaging studies have also implicated neurotransmitter systems. One study in SAD people noted altered serotonergic neurotransmission, which may be caused by a reduction in the serotonin 5-HT1A binding protein in the amygdala, anterior cingulate, and insula. Another study found a reduction in GABA in the thalamus of SAD people. Impaired GABAergic function may contribute to amygdala hyperactivity observed in SAD. The neuropeptide oxytocin has attracted considerable research attention. Oxytocin is produced in the hypothalamic, paraventricular, and supraoptic nuclei and secreted by the posterior pituitary gland. Oxytocin, or OXT, is well known to be secreted during childbirth and lactation. In addition, an increasing body of work indicates that OXT secretion has anti-anxiety effects by reducing HPA activation, promoting social attachment and maternal behavior, and increasing empathy and trust. Of relevance to SAD, OXT plasma levels are reduced in SAD people before and after playing a trust game, which normally increases OXT levels and promotes cooperation and reciprocation in control groups. The reduction on OXT may account for the amygdala hyperactivity accompanied by excessive social avoidance and fear in SAD. Indeed, intranasal OXT administration is reported to attenuate amygdala reactivity to threatening facial expressions, perhaps by promoting GABAergic inhibition in the amygdala. Intranasal OXT also improves self-reported speech performance compared with placebo. The oxytocin system is further implicated in SAD on a genetic level. An OXT receptor single nucleotide polymorphism was found to be associated with negative emotionality and moral judgments. On the basis of these studies, the oxytocin system is a promising target to potentially develop treatments for SAD and disorders related to social dysfunctioning, such as autism. Treatment. The antidepressant SSRIs that include fluoxetine, paroxetine, sertraline, and fluvoxamine among with other serotonin norepinephrine reuptake inhibitors, venlafaxine are considered first-line pharmacotherapies for SAD. These drugs shared similar efficacy profiles and are approved by the FDA for treatment of SAD. However, drug-related side effects such as agitation and sexual dysfunction can be distressing for some SAD people. Also, discontinuation of medication increases the risk for relapse. One study reported that 60% of people with SAD relapsed after discontinuation of sertraline treatment. Alternatives to SSRI and SNRI treatments may include psychologic or cognitive and behavioral group therapies. People with SAD are reported to respond well to CBT compared to placebo. The choice between pharmacotherapy and CBT may depend on the person's preference and access to treatment. Of note, physiologic interventions at the end of acute treatment, or drug treatment rather, appear beneficial in continuing to alleviate the symptoms of SAD and may lower the side effect of long-term drug treatment, leading us to a generalized anxiety disorder. Excessive and persistent worries are hallmarks of generalized anxiety disorders, also known as GAD. The individual worries about life events such as marital relationships, job performance, health, money, or social status. The lifetime prevalence rates of GAD ranges from 4.1 to 6.6, with somewhat higher rates in women than in men. GAD usually emerges in the early 20s, but can occur in childhood. 6 major symptoms of GAD have been identified and include restlessness, muscle tension, irritability, being easily fatigued, difficulty concentrating, and difficulty sleeping. The individual startles easily and frequently suffers from depression and panic attacks. The severity of symptoms fluctuates over time and may be linked to the changing nature of stress. Although GAD tends to be chronic, the symptoms may lessen with age. A frequent complication of GAD is substance abuse, which may result from self-medication with alcohol or drugs to relieve anxiety symptoms. Our etiology and pathophysiology. Female twin studies suggest a concordance rate of 30%, but disease genes linked to specific chromosomes have yet to be identified. Abnormalities in the norepinephrine and serotonin system were reported in GAD. An example, there is a reduction in alpha-adrenergic receptor binding, a decrease in serotonin levels in CSF, and reduced platelet binding of paroxetine on SSRI. Another reported alteration in GAD is a reduction of BZ binding in the left temporal hemisphere. 2 functional MRI studies have revealed alterations in specific brain regions in adults and adolescents with GAD. One study in GAD adults showed that increased anticipatory anxiety was associated with elevated cingulate cortex activity, and both the heightened anxiety and cingulate cortex activation were reduced after 8 weeks of treatment with venlafaxine, a serotonin and norepinephrine reuptake inhibitor. This study suggests that the decrease in the pathophysiologic cingulate cortex activity is a predictor of GAD treatment efficacy. In children and adolescents with GAD, brief exposure to masked, angry faces induced heightened right amygdala activation, which correlated positively with severity of anxiety. The study underscores the role of abnormal amygdala activity in attentional bias or vigilance to threats in GAD. So our treatment: GAD is diagnosed when a person spends at least 6 months worrying excessively and engages in at least 3 of the 6 major symptoms. A 5-HT norepinephrine reuptake inhibitor, such as venlafaxine, or the SSRI paroxetine and escitalopram, have become first-line therapeutics for managing GAD. These medications may produce relief of GAD symptoms within 1 week and are effective in treating comorbid symptoms of depression. Buspirone, which has an affinity for serotonin receptor 5-HT1A, is another treatment option, although the onset of clinical efficacy may take 2 weeks. The primary side effects of buspirone, which lessen over time, include dizziness, headache, nausea, and mild nervousness. GAD non-responders to 5-HT&E reuptake inhibitors or buspirone may be treated with BZs. However, GAD tends to be chronic and comorbid with depression and other anxiety disorders. BZs are usually limited to uncomplicated cases of GAD. In addition to drug therapy, behavioral therapy is used to acquire relaxation techniques that control anxiety. That leads us to post-traumatic stress disorder, also known as PTSD. Exposure to a terrifying or life-threatening event may produce PTSD. Although the disorder was initially described in combat situations and called shell shock, war neurosis, or traumatic neurosis. PTSD does not develop only from exposure to traumatic experiences in the battlefield. PTSD may develop after exposure to threat of death, serious injury, or sexual violation. The disorder may develop within hours of the traumatic experience or after several months or years. The DMS-5 criteria for PTSD lists four diagnostic clusters, described as re-experiencing, avoidance, negative cognition and mood, and arousal. Re-experiencing refers to a spontaneous recollection of the traumatic event, recurrent nightmares, flashbacks, or other intense or chronic physiologic distress. Avoidance refers to distressing memories, feelings, or external reminders of the traumatic event. Negative cognition and mood may occur from a persistent and distorted sense of blame of self or others, from an estrangement from others or diminished interest in activities, or from an inability to remember key aspects of the event. Arousal is marked by aggressive, reckless, or self-destructive behavior, sleep disturbances, hypervigilance, or related problems. The flight or fight behavioral aspect also are associated with the arousing nature of PTSD. The lifetime prevalence rate of PTSD is 7 to 8% in men. PTSD is usually found among combat veterans, whereas PTSD in women is often related to rape or assault. Abused children also may develop PTSD. Individuals with a history of psychiatric illness or those lacking strong social support appear more sensitive to the effects of traumatic stress. So are etiology and pathophysiology. The primary etiology of PTSD is exposure to a terrifying life-threatening event and likely involves stress-induced alterations in several neural structures and neurotransmitter systems. The amygdala and prefrontal cortex are highly involved in the pathophysiology of PTSD because these brain structures normally play important roles of how fearful memories are stored, retrieved, and extinguished. Individuals with PTSD who are exposed to trauma-related stimuli generally exhibit increased activity in the amygdala and diminished activity in prefrontal cortical areas. Persistent dysregulation of the fear-based memory system may underlie chronic PTSD, that is, the failure of prefrontal cortical inhibition to control the amygdala-induced activation of fear compromises the extinction of fear memory. Structural brain imaging studies show that combat-exposed PTSD victims also have a smaller hippocampus, a brain structure involved in endocrine functions and memory formation. Pediatric PTSD studies reveal a more generalized effect of trauma on reducing total brain volume. Other brain sites exhibiting increased activity in PTSD are the dorsal anterior cingulate cortex and insula, albeit similar findings were reported in other anxiety disorders. So again, here is another article. A stress-related protein kinase in the prefrontal cortex is downregulated in PTSD. So again, here's a good spot to pause so you can read this portion, and I'll go further down and pause once more. Let you read the entirety of the module. As in panic disorders, BZ binding is altered in PTSD, as indicated by reduced distribution of BZ receptor binding in the prefrontal cortex compared with healthy controls. This reduction in prefrontal BZ receptor distribution was not found in other brain regions. So our treatment. Chronic PTSD lasting for years may occur in 30% of diagnosed individuals. Paroxetine and sertraline are considered first-line SSRI medications for chronic PTSD because of their tendency to lessen the recurrent nightmares and flashbacks and to treat the high accompanying prevalence of depression and substance abuse. Other antidepressants, such as the TCA, have moderate effects and are second-line drugs. Drugs such as nifazodone and bupropion may provide benefits. BZs may be used in the aftermath of a traumatic event to control hyperarousal symptoms such as irritability, insomnia, and muscle tension. However, there is no clear evidence that BZs have clinical efficacy or provide prophylaxis against the development of chronic PTSD, and BZs should be carefully monitored among individuals with a history of drug abuse. That leads us to obsessive-compulsive disorder, or OCD, which is a chronic disabling illness characterized by the two core symptoms of obsessions and compulsions. Obsessions are recurrent, intrusive thoughts or impulses that provoke an intense anxiety that leads to individuals to perform compulsive repetitive behavioral acts to alleviate the anxiety activated by the obsessions. Although DSM-5 no longer classifies OCD as an anxiety disorder, obsessions are associated with significant distress, and compulsions that are consciously performed to reduce the obsession-related anxiety. OCD is a time-consuming illness that significantly impairs a range of everyday functions, such as social relationships, job performances, and academic success. Examples of obsessions may include preoccupation with contamination, doubting religious or sexual themes, or the belief that a negative outcome will occur if a specific act is not performed. Compulsions are ritualized acts such as washing, cleaning, checking, counting, organizing, and repeating specific thoughts or prayers. Performing the compulsions may provide temporary relief of the anxiety, but also reinforces the dysfunctional thoughts and neural circuits that underlie the negative obsessions that generate the compulsive anxiety. The lifetime prevalence rates of OCD ranges from 2 to 3%, with a slightly higher onset in males during childhood or adolescence. In many cases, the OCD individual also is diagnosed with major depression, panic disorder, or GAD. Among children with OCD, common comorbid disorders include Tourette syndrome, oppositional defiant disorder, attention deficit hyperactivity disorder, and depression. 30 to 50% of adults reporting experiencing OCD in childhood already. So are etiology and pathophysiology. Family and twin studies demonstrate that OCD involves polygenetic and environmental risk factors. First-degree relatives of affected adults also are at risk of 4.6% of Tourette syndrome and tics in comparison with control relatives of 1%. Thus, OCD and Tourette syndrome may share common genes and pathophysiology. Functional brain imaging studies have identified a pathologic brain circuit consisting of increased metabolism in the anterior thalamus, orbital frontal cortex, dorsal anterior cingulate cortex, and especially in the basal ganglia, subregions of the caudate and putamen. Abnormalities in caudate volume in OCD also are found using structural neuroimaging techniques. This neural circuit is activated in OCD people by symptoms, provocation, and reduced by effective pharmacotherapy and psychotherapy. Genetic studies further indicate that genes affecting the serotonergic and dopaminergic and glutamate systems play a major role in the pathophysiologic basis of this OCD neural circuit. So here you're taking a look at the basal ganglion. One particular abnormality in the neural circuit of OCD is the dorsal anterior cingulate cortex. Several functional neuroimaging studies reported hyperactivity of the DACC in OCD. People compared to controls. Furthermore, electrophysiologic studies showed altered biomarkers of cognitive control in the DACC. The DACC is hypothesized to be a key center that receives negative emotional and reinforcing information and integrates that information to direct motivated behavior. So our treatment. Treatment of OCD, SSRIs, including citalopram, fluvoxamine, paroxetine, and sertraline, are the first drugs of choice for OCD. Roughly 70 to 80% of OCD individuals show a partial positive response that may be further improved by other medications. For example, clonazepam, ABC, is found to improve the effects of fluoxetine and clomipramine therapy. The tricyclic antidepressant clomipramine is also used if SSRIs are not effective or are not tolerated by the OCD person. The therapeutic effects of SSRI and clomipramine may be the result of blocking serotonin reuptake and increasing serotonin availability to postsynaptic receptors to stimulate serotonergic neurotransmission in dysfunctional serotonin neurons in the brain of OCD people. Antipsychotic drugs, in combination with SSRIs, are also effective, especially in comorbid OCD and tic disorders. Here, the normalization of dysfunctional serotonin and dopamine brain systems in OCD may underlie the therapeutic effects of SSRI and dopamine receptor-related drugs. Psychotherapy involves verbal interactions between a therapist and the individual to overcome the mental disorder. Several types of psychotherapy are available, but CBT and response preventive therapy are effective in treating OCD. CBT is a problem-focused, goal-directed, and time-limited treatment of the abnormal learned obsessions and compulsive actions. Response prevention therapy involves exposure to cues that elicit distress, followed by preventing the individual from engaging in compulsive rituals for at least an hour or until the anxiety subsides. CBT employing response prevention therapy is found to prolong and produce long-term symptom remission. Because of chronic nature of OCD, treatment in adults may involve pharmacotherapy, psychotherapy, a combination of pharmacotherapy and psychotherapy, brain modulation, or invasive brain methods. In children, the American Academy of Child and Adolescent Psychiatry recommends a combination of SSRI and CBT for those with moderate or severe OCD. However, recent meta-analysis studies find no strong evidence for the superiority of SSRI and CBT combination treatment in comparison to CBT alone for children with OCD. In people with severe OCD who are resistant to pharmaco or psychotherapy, electroconvulsive therapy and transcranial magnetic stimulation may be used to provide some relief of OCD symptoms. An alternative, promising treatment for OCD is deep brain stimulation, which also is used for intractable depression. Deep brain stimulation in the anterior limb of internal capsule, striatum ventral capsule, nucleus accumbens, subthalamic nucleus, and inferior thalamic peduncle is effective in alleviating some OCD symptoms. Stimulating these brain regions may be reducing abnormal neuronal firing in the neuroanatomic circuitry linked to OCD. The long-term treatment effects of deep brain stimulation are still under investigation. Another invasive treatment for people with severe treatment-resistant OCD is neurosurgery. One focus of neurosurgery is to disconnect the basal ganglia from the frontal cortex. Dorsal anterior cingulotomy also is used in the treatment of refractory OCD. Neurosurgery offers significant relief of obsessions and compulsions in 50% of treatment-resistant OCD individuals. That concludes our chapter here today. As always, I thank you all for watching, and I'll see you at the next chapter. Till then, take care and stay safe.